Good morning, everyone. What a wonderful gathering I have. With a plethora of wonderful speakers, I think I'm really excited, like you are, to share my views on this TEDx platform. Friends, I'm sure me being a doctor and a cancer specialist, you would be also wondering what I'm talking about. And I'm going to start with human body. You all know human body is genuinely great craft. It's a structure, it's a function, it's a variations we are born with, always fascinates everyone. I'm sure you know Leonardo da Vinci. This is his picture of a human anatomy. And why I'm showing this picture is, if you look at the human body, you check the central part, if you put a line, in the center, we have only one organ. The God or creator has given only one organ. One brain, one heart, one liver, and I come to my specialty, one bladder. Away from midline, you go, God has given us paired organs, meaning you have 2 eyes, 2 ears, 2 lungs, 2 kidneys. Reason being, if you have one problem or one disease affecting one organ, the other organ is going to take you through the rest of the life, and that's the creation of the God. Coming to my specialty, what I'm going to talk about, you can see both the kidneys around there, but you have a single bladder where you can store your urine. If that gets affected, unfortunately by cancer, we can't remove that, or even if you remove it, what are we going to do? And I think that's the biggest challenge as a cancer specialist we have. Word C is not more any frightening, like diabetes, blood pressure. This is a cancer which is affecting across the length and breadth of the country and across all the economics. The title of the talk, what I'm going to talk to you about, is RRR. I'm sure you all know what RRR is all about, but I'm referring something different. R is radiation for curing the cancer. R is removal of the organ, that bladder, that's another R. But what I'm going to talk about is a ray of hope in 2025, and that's the basis of my talk. At the same time, I'm going to take you through my journey for the last 3 decades, where as a young surgeon who wanted to be a surgeon scientist, walked all along the progress of this cancer specialty. On one side, the cancer was progressing, evolving, it was giving a lot of challenges, and as a surgeon scientist, I also had to face a lot of challenges while dealing with this cancer. So it's a dual journey I'm going to talk to you about. So let us take something basic. What causes bladder cancer? So like any cancer, smoking, tobacco, alcohol, and sometimes the industrial carcinogens can give rise to bladder cancer. What happens thereafter? You have genetic mutations, the cancer changes its phase, and it can create a lot of challenges to the doctors who are treating them. So as you have seen a picture, the bladder is a viscous or an organ. When we treat as a doctor these bladder cancers, we have one chance. The first chance is the best chance. And I always say the battle of the bladder cancer is won or lost in his first assessment. So what we do is, when patient gets or a person gets a cancer in that viscous, we use different technology, which is something called as an endoscope, where a small light goes through the sort of water pipe, goes inside the bladder, and we have, thanks to technology, where we use lasers, we have vaporizations, and we clear these kind of tumors endoscopically. So the patients do not have any cuts or anything on the body, and almost 70% of these bladder cancers are usually treated by these kind of means. So if you take a length and breadth of bladder cancer, 70% are limited to the bladder, and we usually sort of do a classic endoscopy and try and remove these bladders with the lasers. These are few sort of glimpses. But the life is not simple. You have to measure the measurable and make a measurable which is not, the famous Galileo said. So all the tumors, what we look through endoscope, they are not the same. And as a clever surgeon or a surgeon who's specialized, should be able to identify which are the worst ones, which are going to give problems, which are the non-lethal ones. And then, thanks to the technology, we have devised many new gadgets now, which will tell you which ones are really nasty and which are not nasty. So these are something called as a blue light cystoscopy, where we actually can identify which cancers are going to give a problem, which cancer not. During my talk, I'm going to tell you the stepwise, the progress what we have in a bladder cancer, and very, very important innovations what we had. So the point I'm making is, all the innovations what we have done in endoscopy in looking these bladder cancers were to identify the wolf among the sheep, and then you can have a good cure rate in these kind of patients. Now, once we remove these tumors keep on coming back, and the patients would keep on asking, doctor, what are my chances of getting completely cured? And I think the scientists, surgeon scientists, the urologists, the cancer specialists, about 50 years ago, were struggling and battling to find out how we can cure this. And then this BCG, I'm sure you all as a child would have had an injection in the arm to prevent tuberculosis. And this came to the rescue. So this was eureka, eureka moment. So people started using this BCG vaccine into the bladder to prevent the recurrence of the bladder cancer. And the credit goes to this gentleman, Dr. Morales from Canada. And this is so simple treatment, but it has a little bit of side effects as well. Recently, he gave a talk after 50 years of sort of invention of this BCG, which is used to sort of cure the bladder cancer. Remarkable journey. So this was a wonderful sort of an important milestone in the treatment of a bladder cancer. As a young trainee, my story, I had entered the field of urology during around that time, and I was fascinated with this sort of BCG, and we started working more and more on a bladder cancer. Another gentleman, I think, Dr. Soloway, he is from Miami. He worked on another molecule, which is called as a mitomycin C. Remember, he spent his life working on the animal labs and used another molecule apart from BCG to put it in the bladder, and many patients were saved. He's a wonderful human being working for the last 5 decades. And also credit goes to Dr. Donald Lamb from USA, who did a lot of work on the BCG. So it is on the foundation, it is the shoulders on which I think the bladder cancer treatment started evolving to the rest of the world. Taking my story, I go to United Kingdom in 1992. The first phase where I go, where we see huge amount of bladder cancers. We had big names, people who have contributed to the surgery and urology, so it was a big learning for me. I thought, as a surgeon scientist, I should also contribute to this field. So we started working on a simple urine test. People keep on asking, what can we do to diagnose a cancer? It is symptoms, it is a scanning, it is what test we do. And here we started working on a simple urine test using an antigen for a cancer. And this was sort of a small contribution I made it for the bladder cancer. Thanks to all my mentors who actually pushed me towards this direction itself. Moved to Edinburgh's Hospital, Cambridge, where we could do more and more work. And this time, the challenges was, if you have a slightly higher grade of cancers, do some molecular testing and genetics in terms of treating this kind of bladder cancer. So friends, we talked about 70% of these cancers usually are limited to this viscous or a bladder, where you don't need to remove this bladder. We can remove these sort of tumors endoscopically with the lasers, and as our predecessors have given BCG, mitomycin, you can save the bladder. So patients are very happy. But the life is again not simple. The cancer keeps on giving you challenges. So here you see I'm showing a picture. The bladder has multiple walls. It has a mucosa, it has a muscle, and if the cancer starts spreading into the muscle, what do? The challenge is they are not amenable to the treatment of endoscopy. So what we need to do is, like any other cancer affected organ, you have to remove this organ. So we're coming to the second R. So remove the organ or give a radiation. And as I said, God has given us you only one bladder. We can't replace brain, which is again a single organ. We may be able to replace the heart, but very, very rarely. We can replace liver, but you can't replace bladder. So what do? So this is a cancer-affected sort of a bladder which has been removed completely. So we used to divert the urine outside. People used to have a bag. People used to get cured, and they used to say, thank you, doctor, you saved my life. But if you asked about the quantity of life, they got the quantity, but they never had a quality of life. Nobody would like to have a bag on the tummy as sort of having urine storage. So one of these patients who got cured, they said, doctor, nothing pleases a man or woman more than being able to preserve their own bladder. And this was a patient survivor. Then the process starts. Last 5 decades, like we have seen so many big wigs who have contributed to do something to put smiles on these sort of bladder cancer patients. The philosophy is, once you choose hope, anything is possible. With that background, in late 80s and 90s, there were a lot of places across the globe where people started using intestine, man's intestine or woman's intestine, to create a new bladder. You can imagine the intestines are made for digestion. So how can you take an intestine to create a new bladder? So the whole evolution started in 70s and 80s, and I was fascinated, and I started going from UK to Europe to Egypt to Canada to Australia, and these are the places where I actually went and saw the big people who contributed to create a new bladder from an intestine. So this was a big second step in my journey as a bladder cancer. This is Dr. Studer from Bern in Switzerland. This is Dr. Mohamed Ghonim from Egypt. They started doing these techniques way back in 80s and 90s. So I'm going to tell you what it is all about. So you have kidneys on the top, you have this bladder, and it means that you have to cut open the patient. But I always felt healing takes a courage. We all have a courage, even if you have to dig a little, find out. And what was this digging about? This Dr. Studer devised a new technique of doing sort of a new bladder. So you all are sort of an audience who knows about human anatomy. So I hope this doesn't upset you. You have a large intestine and a small intestine. We take a small piece of intestine. We configure it into a U shape because it's not an intestine we have to take it. You have to give a shape of a bladder. So we take about 50 centimeters of intestine along with the blood supply and a nerve supply, make a sphere out of it because the bladder has to be of the same capacity. It has to have the same sensation. So what we do is we create a sphere from that small piece of ball or intestine which we have pinched it from a human body, and then create a sort of a new bladder which will flake or function like a bladder. So this is how you see a picture here. We take an intestine along with his blood supply, and this is the operation which has been done. And if I show you pictures, the patients would not have any sort of a bag on the tummy, but they would have an own bladder. Can you imagine anybody donating a bladder to somebody? Not possible. They can donate kidneys, they can donate liver, but nobody would donate anybody's bladder. So this is created from intestine. So this was a huge revolution which took place in the 80s and 90s, and it was wonderful for me to go all around the globe, learn these techniques from these people, interact with them, and these patients were now more happy. And they said, "Thank you very much, doctor. You gave me a quality of life as well as a length and quality and quantity of a life." But the life is all about refinement and the progress, whatever you are doing. You shouldn't be happy about it. And as challenges started coming, there were people who were treated with radiation, so I devised a new technique by using staplers. Can you use staplers in the abdomen? Yes, we started using staplers. This was way back in 1990s. And these are the few people who have contributed significantly to the growth and the treatment of a bladder cancer. Dr. Ashish Kamath from MD Anderson Cancer Center, Dr. Badri Koneti from Minnesota, and Dr. Soloway. These were all people who we started interacting and exchanging our ideas, and that's the way to go forward in future. Another gentleman in the blue jacket is Dr. Who has done so many operations of more than 2,000, Richard Hotman, and he has also shown the way how to progress in terms of bladder cancer. The next step refinement is this operation was making a cut on the body. And the patient said, "We are ashamed of a scar." But it is not to be ashamed of scar. It simply means you are stronger than what you are trying to hurt you. You are stronger. But people said, "Can we do something better?" And the robotics have come in. So use the robots now. With the robotic, you can sit on the machine. You have to operate. But rather than having a scar, you can put all those robotic arms in the abdomen, and you can remove the bladder and do that. And as I said to you, the life is evolving. You do more and more work. You feel you have achieved your goal. And then we started getting patients. Imagine a lady who's pregnant. She has a baby in the abdomen, and she has a cancer in the bladder. So we have a choice how to save the baby, how to save the bladder. We have to save 2 lives. So I've done a good amount of work on this aspect as well, how we deal with these urological cancers in pregnancy. Now, we are moving towards putting some devices in the bladder, where we don't need to remove the bladder, the devices stay inside and keep on killing the cancerous cells. So that's something new evolution would be taking place. The last R I talked about is now immunotherapy. We all talk about radiation, we talk about chemotherapy, but now we are talking about immunotherapy, which is a new ray of hope, which is a little bit toxic, but it has given wonderful results in the life. The whole world is talking about now artificial intelligence. Now, does it mean that people like us who are surgeons, scientists will get outdated? Not at all. Artificial intelligence is going to tell us which cancers are worse, which cancers are benign, which cancers are non-lethal, and how we can sort of deal with these sort of patients to give them a good quality of life. Friends, we will be happy if we can give a good hope, prevention, and eradicate the cancer completely in coming years of time. The Forbes has taken notice of it. They keep on highlighting what kind of work has been done. We have formed recently a group called as IBCG, International Bladder Cancer Group, presided by Dr. Kamath, which I showed. The whole idea of having this group across the globe is to exchange the ideas and do something more and more in terms of bladder cancer. The patients are always in the focus, because what we do with the patients, we feel is great. But unless you have a coalition of the patients, they will tell you how they're doing, what their needs are, and I think this is another group which I'm part of, the World Bladder Cancer Patient Coagulation, that also tells us how to proceed and sort of try different kinds of treatment in future. I think I should be grateful to the places where I've been working so far. Friends, somebody asked just now what TED means. Technology, entertainment, and design. So I showed you a technology in the medical faculty. I showed you what design is. Certainly it was not an entertainment, but more of an infotainment. So from RR to new R, I'm sure you have witnessed a journey of 3 decades in coding and decoding of a bladder cancer. Friends, cancer is a word, it's not a sentence. Cancer is one of the chapters in your whole book. So finish that chapter and move on. This is what I personally believe. With all that 3 decades of work, I'm happy to say that, yes, it is a cancer, but we have an answer. Thank you very much. It was wonderful to be on a TED platform.